crossed a few oceans, and I think we are crossing a few oceans. Our next speaker is from Utrecht, Dr. Marc Jansen. Marc is a pediatrician and a researcher at the University of Medical Center in Utrecht. He obtained his MD from the University of Utrecht, completed his pediatric residency at UMC Utrecht, then received his Ph.D. in pediatrics from the University of Utrecht. He's a leading expert in pediatric nephrology with a focus on juvenile idiopathic arthritis. His research has been very widely recognized. He's received numerous awards, including an honor of best paper from the European Society of Pediatric Nephrology. He's published numerous papers in peer-reviewed journals, and his research interests include pediatric nephrology, particularly juvenile idiopathic arthritis, and has a focus on the development of biomarkers and the prediction of models for disease activity and flares in children. And Marc is going to talk to us today about the Utrecht JDM cohort and flare predictions. So Marc, I would invite you to give your presentation. Thank you.
Can you all hear me?
We can hear you. Your presentation came up and then it seems to have disappeared again.
But you hear me as well?
Yes, yeah, your presentation's back up, yes.
Perfect. So thank you so much, Andrew, for the invitation. It's a real honor to speak here for QGM, and I also want to acknowledge the great work you do in the field of JDM. So I also I work as a pediatric immunologist and rheumatologist in Utrecht, and indeed my talk will be on the Dutch cohort, flare prediction and development of an interferon-based score. I think you also mentioned nephrology. I know something about that, but that's not my specialization at this moment. So I have no disclosures, but I have to say I have a lot of pleasure on this moment as I'm working on Aruba as part of a collaboration between the Utrecht Hospital and the hospital here. And I see quite some autoimmune disease and inflammatory diseases, but the most common inflammatory disease here is of the skin, as you can see. So my presentation will mainly be about this patient. I will call her Sophie here because of privacy reasons, but this girl in this case was actually one of the reasons I really dive into JDM research, and I'll tell you why. So this girl came in at the age of 11 with progressive malaise. She had difficulties with standing up out of bed and morning stiffness. And on additional research, they saw a normal CRP, slightly elevated ESR, a mild anemia, and thrombocytosis. And at that moment, she was actually diagnosed with a parvo infection. However, she had increased liver enzymes with an ALT of 360 and AST of 920, and therefore she was referred, of course, to the pediatric gastroenterologist. They thought, might she have an autoimmune hepatitis? She also had an elevated IgG, but her specific antibodies were negative. And also the biopsy was not a clear autoimmune hepatitis. Nevertheless, they started IVIG. It even gave some effect on the patient, but 2 months later, you can see that at the blue arrows here, she had redness of the face, weakness, and a rising AST. And then a colleague of the gastroenterologist came in and said, hey, this AST looks much more elevated than the ALT. What is the CK? Well, the CK was more than 26,000. So that kept things rolling. And then she came to our department, pediatric rheumatology. And we saw a girl with severe muscle weakness, very positive cower. She could not lift her head from base. She could not roll over. She had livid eyelids, got papules on the MCPs, dysphagia and achalasia. She had very high interferon serum biomarkers, one of the highest we have in our cohort, collecting 9 of 230,000. She was ANA positive and she had specific antibodies, anti-PL7. The MRI showed diffuse inflammation of practically all muscles. There was not a muscle biopsy performed, and we did CT scans of the lungs, and unfortunately she had interstitial lung disease with already an impaired lung function at diagnosis. So her diagnosis was JDM with antisynthetase syndrome, and unfortunately there was a delay of at least 5 months after the first symptom. And this patient and her parents had a lot of questions. So how many children would have JDM in the Netherlands? What about comorbidities like ILD? How can we create more awareness to prevent delay? And why does my child get this disease? What's the best way to diagnose the disease? Do we need a biopsy? What's the best therapy for our daughter? What are the side effects? And what's the prognosis? And of course, a lot of these things we can find in the literature already from other cohorts, but we didn't have a decent Dutch cohort. And that's the reason why we decided for our first aim to look at the Dutch demographics, incidence, treatment, and outcome. So that's what we did. And we also wanted to look at the interferon serum biomarkers, but then in a nationwide population. We want to compare the different diagnostic tests and to look at the treatment and more specifically the use of steroids in our cohort. So I was lucky because I came in a team with long-standing JDM research experience, and Annette van Rooyen, Professor Annette van Rooyen and Femke van Wijk started this up, and that's why we already had a very well-described prospective cohort in the Netherlands. This already started in 2007, but since 2015 it's complete. So that means that all centers treating JDM are included, and we have all the patients in the cohort. We also have multiple international partners where we work very well along. And we collect demographic data, prospective clinical data, and serum, plasma, and cells at diagnosis, at fixed time points, and also at flares. And we can also collect samples via diagnostics. So Laura van der Grient is a student who did a lot of work on this project. So are the results. We had 83 patients in the Netherlands, 65% female, median age 6 years. We had at least a follow-up of 3 years, and the incidence was 2.85 million cases per million per year, which is comparable with other cohorts. The most common features were proximal muscle weakness and Gottron papules or signs. I thought there was quite a high percentage of dysphagia at diagnosis, which shows the frequent involvement of the bulbar muscles and therefore the severity of this disease. We had 4 patients in the cohort with an impaired lung functions, and 2 of them already had ILD at diagnosis. And there was a very strong positive family history for autoimmune disease in our cohort, up to 43%. Interestingly, we looked at the different tests at diagnosis, and we know this from literature. CK was not very reliable. Only 73% was positive, while we only had 4 or 5 amyopathic patients in our cohort. AST actually was quite sensitive, which we also saw in the case of Sophie. And very interestingly, in our nationwide cohort collecting 9, an interferon-induced protein was present in 100% of the patients. So MRI was quite sensitive and was positive in 91% of the patients. Biopsy was not performed in all patients and was done in 27, was abnormal in 20, and of those, 3 had very extensive clinical, biochemical, and radiological evidence of myositis. So there is a certain risk of sampling error. Then we were interested in the treatment, and since 2015, all patients were treated according to PRINTO in the Netherlands. That means methotrexate and prednisolone, and there's one center who often adds IVIG. And we specifically want to look at the prednisolone dose, and that was quite shocking because we saw that about 58% of the patients 6 months after diagnosis was still on steroid doses, prednisolone doses above 0.2 milligram per kg, and even 22% was still on doses above 0.4. And that's something that gives severe toxicity, and that's also what we saw, because this cohort is not designed for precise adverse event calculations, but still self-reporting and considering a recall bias, we saw 48% severe Cushing syndrome. We saw a lot of mood swings, problems with bone density, hypertension, and other side effects. And this is an underestimation. We're now looking into a prospective prednisolone study, and we see especially the mental side effects are really common. So what about the outcome? We saw that 40% of the patients had a total of 56 flares, and this is something we also see in the literature, and 83% of those occurred on medication. And so far we had no patient who died from JDM in this specific period. So in conclusion, the incidence is comparable to other countries. We have up to 100% interferon type 1 and type 2 upregulation in national population. MRI appeared to be very reliable, and 58 of the patients were still on more than 0.2 milligram per kg at 6 months post-treatment. 40% of the patients flared. What about Sophie? So she got also methotrexate and prednisolone, and there was added Cellcept because of the ILD, and she actually recovered quite well. We could wean the steroids. Her CMAS became normal. The ILD, of course, didn't disappear, but her lung function improved. She was doing quite good. We could even build off the methotrexate, but then in 2023, almost a year ago, she unfortunately experienced again shortness of breath, a little bit coughing at night, and some weakness, especially of the arms. And then she appeared to have a flare, again with CK elevation, and also the interferon biomarkers went up. And indeed, we saw again on the T2 weighted images, severe muscle inflammation and also a worsening of her ILD. But then, if we look back to her biomarkers, we saw actually that they were already starting to rise 1.5 years ago. And this was something where we were thinking, what happened here? Was this subclinical inflammation? Was this a sign that we should not have tapered the medication here? And that brought us to our next aim, and that is, can we predict the disease course and flares with galectin-9 and CXCL10? So these two markers have been validated in international cohorts, and they're actually implemented in routine diagnostics and are now part of our national guideline. And Saskia, we all know, worked on this project. So we looked in a pilot data set to combine the longitudinal clinical and biomarker data with a statistical model called latent class mixed effect models to define the different disease trajectories. And we did that in this pilot data set with 81 patients with JDM, with a median follow-up of 12 months, 9 time points per patient. And the clinical data we included were PGA, FAS, CMAS, and the ACAT activity score. And we looked on biomarkers, CK, galectin-9, and CXCL10. And what we saw is that with this model, we could distinct 3 different disease courses. The majority of the patients, if you look at physician global assessment scores, start on with high disease activity, but then become low and stay low. Then there's a group of 20% who around 19-20 months start to flare and have disease activity again. And there's an even smaller group who actually never come into remission. And this last group was particularly having skin disease. We also saw that class 2, the flaring group, had higher interferon biomarkers than class 3, although these were still small numbers due to the pilot data set. We could also make this graphs with CXCL10. And there we see that there are two classes. Again, the first class who start high with CXCL10 and then comes down to 0. But the other group who's starting again at around 18 months with higher CXCL10 levels. And what was very interestingly, if we looked after 25 months post-diagnosis, all 3 patients that flared were in the group we had rising CXCL10. So this is not proven yet, but it's at least a very strong sign that the increase of these biomarkers can predict a flare. So LCMM identified distinct disease trajectories in line with the disease courses typically seen in clinics, and these rising levels of biomarkers might be indicative of an upcoming flare. The next step is, and we're already doing that now, is with our international collaborations, we have much larger numbers to validate these findings, and we also need other analysis, especially joint modeling, to prove this prediction of flares. So back to Sophie. How should we treat her now? Now she's having a flare. Should we give methylprednisolone, rituximab, IVIG? And if the interferon pathway is so dominant, should we give her interferon pathway inhibition? And what should we give her then? Because we know that we can block the interferon receptor, we can block JAK, we can block TYK2, and we have all kinds of inhibitors. And this was something we wanted to find out in more detail, and that's why we started in vitro studies. And again, Saskia worked on this, and we established another biomarker, a serum biomarker, which was Siglec-1, which was correlating very well with disease activity in JDM, and we used this in our in vitro model. So this is the setup which we used for the experiment. So we used PBMCs from healthy controls, cultured these cells with different types of inhibitors for 1 hour. And after 1 hour, we stimulated the cells with either interferon alpha or interferon beta. And then we did that for 18 hours, and then we measured Siglec-1 on the monocytes. And if you look at the first figure, we demonstrate here that Siglec was indeed induced by both interferon alpha and beta, and that if the cells were pretreated with a type 1 interferon receptor antibody, the Siglec-1 induction was again inhibited. So Siglec-1 is a good readout. And here we have studied the different JAK and TYK2 inhibitors. So you can see the conditions. Stimulate with interferon alpha at the left and interferon beta at the right, and then you see the different concentrations of the inhibitors. So filgotinib, tofacitinib, baricitinib, ruxolitinib, and deucravacitinib. So for all the JAK inhibitors, we see a dose-dependent inhibition of Siglec induction, and the lowest concentration of 0.1 micromolar was not effective, except for deucravacitinib. It was very potent already at this dose. And when comparing interferon alpha and beta, it's overall quite similar, except for filgotinib. As a next step, and this is interesting, we used the plasma from JDM patients instead of interferon alpha or beta to stimulate the cells. And as you can see on the left figure, plasma from JDM patient diagnosis was able to induce Siglec-1 on healthy monocytes. And this induction could be inhibited by either the anti-receptor antibody, deucravacitinib, or baricitinib. We also saw that when plasma collected from patients during clinical remission, there was no or very minimal induction of Siglec-1. And as expected, the plasma from healthy controls did not induce Siglec-1 at all. Interestingly, as shown in the right picture, when we correlate the level of Siglec-1 induced by patient plasma to the PGA VAS score, we found an almost perfect correlation. So these results indicate that the assay is a potential inductor for both treatment response and disease activity. So Siglec is very suitable in vitro as a readout for type 1 interferon activation and also correlates with disease activity. we have a dose-dependent inhibition of cyclic 1 induction by the different inhibitors. And what we want to do now is that we validate this assay in samples from JDM patients who have actually been treated with a specific inhibitory agent. So what's our future aim? Of course, we want to go from in vitro to in vivo. So what we have up to 100% interferon upregulation in our newly diagnosed JDM patients. We have multiple potent interferon inhibitors showing in vitro and in vivo potency in JDM. But what we want is to bring the best inhibitor to newly diagnosed patients. We want to create an integrative interferon-based score that is able to stratify JDM patients at disease onset that may benefit from interferon inhibition. Also, it has to be able to predict flares and to guide safe tapering of these therapies. Luckily, there's now a very important trial going on in France, which will give the first answers on baricitinib in newly diagnosed patients. We had a very interesting meeting in September, international meeting, to see how we can get to an international trial where we can bring JAK or other interferon inhibitors in newly diagnosed JDM patients. Although it's still hard to find funding and to get pharmacy along. But let's go back to Sophie, where it all started with. Because of the ILD, Sophie was treated with rituximab and methylprednisolone pulses. We restarted methotrexate. And during these therapies, she was able to pass the high school exams. Her lung function improved. She actually is living a normal life now again. She's now stable on CellCept methotrexate, but still B-cell depleted. But the question is, what should we do when she flares again? Research to be continued. Thank you for all my collaborators, especially Femke van Wijk, Annette van Rooyen, and Saskia Veldkamp. And please, please don't ask questions.
Thank you, Marc. The session is now open for questions in the chat box. I might just start off. When you were looking at your in vitro model and you were testing out the different JAK stats and the TYK2, it seemed like between the two experiments where you had, in the second experiment where you stimulated the PBMCs with a JDM sample, it seemed like baricitinib and deucravacitinib swapped around. Deucravacitinib in your first study seemed to be, from a dose dependency, extremely active, whereas when you actually did the stimulation with JDM, they swapped around. I was just wondering if you'd like to comment on that.
Yeah, that's true. We were also a bit surprised. I don't know why it's happening, and therefore it's really interesting now to look into the samples from the patients who've actually been treated with one of those, especially with baricitinib, where we get those samples and then we get the answer which one is more sensitive. Well, we first thought, can it be a difference in interferon alpha or beta, but actually that didn't differ so much if you looked at the two graphs. So I don't have the answer for us, but you're right that was actually a bit surprising for us.
Okay. We have another question in the chat box from Michael Miller. Did you see a relationship between the degree of interferon upregulation and which myositis-specific antibody was present?
Not yet, but that's because we didn't look yet. And this is the pilot data set. We will get more than 200 or 300 patients in the complete data set, and then myositis-specific antibodies will definitely be one of those variables which we will put in the model. Also, France saw different responses in different patients. So, and then I mean responses to interferon therapy or blocking therapies. So this will definitely be in the definite analysis, but we didn't put it in the pilot model yet.
Okay, if there are no further questions, thank you, Marc, for a wonderful presentation, and we look forward to seeing the results as the studies continue.
Thanks a lot for the invitation.